We're from Mayo Clinic, and we'll talk a little bit more about Mayo Clinic in a bit. But I'm Dr. Matt Hoerth. I'm an epileptologist for adults. We have Dr. Kruger, Dr. Kelly Kruger here, who is internal medicine and pediatrics trained here, and we'll explain this whole thing as we're going to do through here. This is Nicole Schuren, our pediatric social worker that works with us. And this is Dr. Chelsea White. Dr. White is our fellow in epilepsy this year at Mayo Clinic in Arizona. So thanks for joining us here today. The purpose of our talk here is to talk about transitioning your healthcare from the pediatric world to the adult world. So I know we got put in the adult box here, or in all the different sessions. But this is actually kind of helping younger people kind of launch into life, and how do we do that? But before we jump into that, I'm going to just spend a couple moments, and we're each going to have kind of our talk, our part of it, talking about Mayo Clinic, because people may have heard of Mayo Clinic, but just quick 2 minutes about Mayo Clinic. It's actually kind of a network of multiple hospitals throughout the country. We kind of represent our Arizona chapter since we're kind of closest to California here. Our biggest site is up in Rochester, Minnesota. One of our colleagues yesterday, Dr. Nicole, talked about genetics in one of the pediatric sessions, and she was here. She's been around. And then we also have a spot in Jacksonville, Florida. We also have an extensive network. If any of you guys are from the Midwest, from Minnesota, Wisconsin area, there you go in the back. Yeah, love it. We have an extensive smaller hospitals throughout, but these are our three main campuses. And then we have this thing called a Mayo Health Network, where we actually kind of partner with a lot of other hospitals to get them extra information and resources kind of throughout the whole world, really. Yeah, I'm sorry. This is the only, we're not really braggy. I don't know why I left this in, but we do okay, in terms of neurology and neurosurgery, we're relatively top ranked if anybody cares about U.S. News and World Report, which some people do, but anyways, we feel like we know what we're doing. But we do live by this motto at Mayo Clinic, and hopefully you'll hear that through our presentation, is that there's this quote by one of the Mayo brothers who founded our organization, which is, "The best interest of the patient is the only interest to be considered." These things are plastered on our walls, and we kind of live by it, and we're really in it for patient care. We're a nonprofit organization kind of dedicated to doing this. So we have the highest level epilepsy center, kind of advanced diagnostic tools, kind of the latest and greatest technologies, essentially, as you guys have probably been hearing from other people as well. A lot of great centers here, nothing to kind of do that. But that's just kind of who we are, just in case you didn't know about Mayo Clinic. So the objectives really today are to talk to you guys about, as I was saying, as people are filtering and transitioning between, pediatric care and adult care, and what it kind of takes to do that. And so that's why we've kind of put together a panel here to discuss these different things. And so, you know what, this video is not going to work because we're not hooked up to the Wi-Fi. Sorry about that. We have a fun video.
You could do a little dance.
No, I don't think you guys want to see that. We got a good parade in the parks, those things. Maybe later, but good idea. But I'm gonna have Nicole start us off with talking about what transition is. What does it mean to transition?
Hi, everybody. So for those who may not be familiar, when we talk about transition readiness, we are really thinking about a process that is planned and purposeful for our patients who have a pediatric chronic illness moving into the adult side of medicine. And it takes a team to do this. So we want to prepare our youth for what it's going to look like when they get to the adult side. And we want to make sure that they understand what their chronic condition is. And in this case, it would be epilepsy. So we put together a comprehensive team, which includes all of us here, but then we also have a child life specialist, and then we'll add any other clinicians or providers that might be helpful to the family. And we create a process which includes not only the medical team and the patient, but you as the family, and then other caregivers, and sometimes even the school and other sectors of that patient's world. Transition readiness is a pathway. It is not one and done. It is something we need to be thinking about early on before the child is 18 so that we can properly prepare them for what happens when they turn 18. Our assessment is geared towards strengths and goals for the patient, but also for the parents and guardians. So just so we're clear, a chronic medical condition is prolonged, not easily resolved, and requires ongoing attention. Ideally, we would start having these conversations pretty early within the onset of the diagnosis. We want to create a routine in our families of this discussion about your child's health. We want to begin as soon as possible, as soon as they start to understand what's going on. And we want the transition discussions to also begin with your pediatrician. So if you are currently working with a pediatrician and he or she has not discussed what's going to happen when your child turns 18, I encourage you to advocate for those discussions now. It's never too early. And we'll talk a little bit about what that looks like and what kinds of things we could be thinking about at different ages. When we discuss our transition readiness amongst us as providers, we're doing an assessment for the patient's readiness, but also for the parent's readiness, because we know this is a family system. And just like you're trying to prepare your child to move along, you have to prepare as well. So we talk about goals. What are your goals as a parent? But what are the child's goals as well? And sometimes those align, and sometimes those do not. So we really try to get on the same page and just understand where everybody's coming from. As Dr. Hoerth mentioned, we are an adult institution that's pulling in our pediatric patients. So when we speak about transition readiness, it comes from that lens. We are not a pediatrician pushing out to the adult, we're bringing them in. So it's really important for us because sometimes we don't have that history with our families where we've had them since childhood, right? So it's really important for us to understand what your goals are as a parent, but then also what your child's goals are. And we kind of create like a roadmap to make sure that the expectations that you have and the expectations that the patient have are realistic, right? And my job as the social worker is really to make sure that you're connected with the proper community resources, and I help make those bridges for you. It's really important that we talk about and start to plan for healthcare transition because we want our patients and your children to be more competent and really work on their health literacy. If your child today was in an emergent situation and you were not there, would they be able to articulate what medicines they're taking, who to call? Would they be able to tell emergency personnel what's going on with them? These are the things that we try to talk with our families about in order to help build those life skills and prepare them for independence. There's also a big component with our child life specialists related to coping strategies within that medical system. Many of our patients come from the pediatric world, and let's face it, sometimes that's not been really a positive experience for a lot of our patients. Even in the adult world, there is such thing as medical trauma. So we want to learn about what works for you, what helps you cope in these dire situations, and how we can help make those situations a little bit more tolerable. We want to educate on their personal health, so we not only look at the medical, but we look at all of them, the whole person, to really find out what is going on and who they are within their diagnosis of epilepsy. Our goal is to help create functional adults in society, and what we're assessing is where they belong in that. If there's a trade, school, or a career that they want to focus on, or we have some patients that aren't able to work in those situations, so then what does that look like for the family dynamic as we're getting older and as you're getting older? So in transition readiness on the adult side, we're really incorporating the fundamentals of pediatric care with the expectations of adult health care by providing education and guidance. If you have ever been to the doctor as an adult, you know that the system is quite different than it is in pediatrics. So this is a big jump for parents who've been advocating for their children all this time, 18 years, 21 years, but it's also a big jump for that patient because this is a different world on the adult side. So we really want to help to temper that expectation of what it's going to look like. We want to be sure that we're providing a secure space for not only you as the parent, but also for the child as well. You've been with your pediatrician a really long time. You've been with your epileptologist a really long time. And then to come over to the adult world is a bit of a shock. So we want to be sure that we're providing some comfort and some safety for you. And the confidence as well that their child can be cared for in that adult health system. So our goal is really to be sure that we are helping your child on their healthcare journey to become more independent. So now we're going to have my friend and colleague, Dr. Kruger, speak from the medical perspective.
Good afternoon, everyone. So my name is Kelly Kruger, and I will lead off by saying that I'm not an epilepsy specialist, okay? So I am a physician, but I'm not a neurologist, and I'm not an epileptologist. But I'm a part of this team because we really feel like as a transition process, a generalist, primary care in the adult setting is very important, right? For you as a patient, for your family, right? So, and so we're going to talk a little bit today about what that looks like from a general perspective, right? And why it's really important to make sure that as an adolescent or young adult is transitioning out of pediatric care and landing in adult care, that it's important that that landing comes with general primary care or general internal medicine in addition to excellent neurology care. So you all have your own lived experience about healthcare transition, right? So, and that's so important. And even outside of individual patient stories, we know as a medical community that healthcare transition is really important, right? There are some basic fundamentals to that because kids continue to age into adulthood every single year, right? So this is a non-stop population. We're always rolling into adulthood. We know that there are millions of kids between the ages of 18 and 21 who are going to age into adulthood every year. We also know as a society, as a medical community in the United States, that adolescents and young adults with chronic illness, that includes epilepsy, but that is not just epilepsy focused. That is inclusive of many other chronic conditions. We know that those adolescents and young adults are at very high risk for bad things to happen in this teenage and young adult time frame, right? And we'll talk a little bit about why that is the case. There's a lot that happens in adolescence, right? And there's a lot that happens to our teenagers and young adults as they are growing up and figuring out who they are as adults. And then there's also a lot that happens with their epilepsy or with whatever else is they're managing, right? And there's a lot that happens about being in high school or being in college or going to school or trying to figure out what you want to do in the world. So all of those things make this a high-risk time. And so we know that it is very important. This topic is very important. We work in Arizona, and in Arizona, the state has identified healthcare transition as a particular area of focus, and Arizona is not alone in that, right? So there are many other states that have identified this at a national level, but also as a state level as something that we really need to be focusing on. We don't do a particularly good job as medical professionals, and I will own that myself on behalf of all the doctors and nurses and PAs and nurse practitioners and everybody else in the room. We don't do a great job with this, right? So if you are sitting there in the room today thinking, nobody has ever talked to me about this, sadly, you are not alone, right? And that is that has a lot to do with the way that we approach this even in medicine. So there are periodically surveys that are done for families and for healthcare providers about whether or not we are doing anything in medicine to address this question about transition planning. And we don't do a very good job. Our statistics are really poor, as you can see on the slide, right? So about 2/3 of the time, we don't even talk to our teenagers or our young adults by themselves, right? And that's really important. if we're going to eventually encourage our adolescents and young adults to be as independent as they can be, right, it's important that we address them independently. And we don't do that very often, right? And again, that's us as medical providers. We often default to just talk to the parents because you as the parents have a lot of great information. And that's not to discount that at all, right? But it is important that we as medical providers leverage you as the parents and also start building relationships with your teenagers, with your adolescents, with your young adults, so that we can encourage them in this process of independence. And so that's on us. But I would encourage you all, if you are in a situation where that's not happening right now, to echo what Nicole said earlier, advocate for that to happen, right? So bring that up at your visits with your providers. We also don't do a very good job in general in medicine about talking with our patients and our families about what happens when our patients reach the magical or not so magical age of 18, right? So because we know that 18 is an age on paper that is not always very relevant medically or life-wise or anything else, but there's a lot that happens at 18, 21, 26, all these times. And it's really important that we have those conversations well before those deadlines are coming up. And I will tell you, and again, I'll own this, that we don't do a very good job. So I would encourage you all to start bringing these things up yourselves if your providers, if your clinicians are not doing so already. To speak a little bit about that high-risk time in life, and I know that we are speaking about epilepsy here today, but as I mentioned before, we know that teenage and adolescent years, young adulthood, is a very high-risk time for patients in many situations, right? So there are many, many medical studies that show that our teenagers and young adults have a hard time with their chronic illness. So you are all familiar with epilepsy. I'll bring to your attention some of the data that's here. This is a study that came out looking at patients with type 1 diabetes. Blood sugars are super high in our teenagers and young adults, generally speaking, right? So the same is also true in how our patients utilize healthcare. So this is data from a study that was in patients with sickle cell disease, right? Much more often are they going to the emergency room, going to see the doctor, getting hospitalized in that young adult time, right? So we know that this is really important, and we need to address this for our families and our patients. If we were to ask ourselves, why aren't we doing a very good job? So we already said it's very important for all of these reasons. Why are we not doing a very good job? We know that there are some barriers there, right? And I'm sure that if we polled the room today, you all would be able to list your top 3 or 4 or 5 reasons why the process of transitioning from your pediatric epileptologist to your adult epileptologist is scary, difficult, impossible, whatever you want to say, right? So, but there are many reasons why that's the case. Some of those reasons are on the provider side, and some of those reasons are on the patient and family side, right? So, and some of them are listed here on the slide. But just to highlight a few of them, there's definitely a fear about a new provider, right? Especially for those of you who have been managing with your kids their epilepsy for much of their childhood, right? The concept of leaving that and moving to an adult provider who doesn't know your child as well, doesn't know you as well, is scary, right? And it's not just about the doctor, right? It's about the nurse who answers the phone. It's about who sits at the front desk. It's all of those things, right? And so that's scary, right? And so that makes this difficult, right? And we recognize that. There are certainly some difficulties with our systems, right? So we've had a lot of conversations at the booth this week about the idea that our healthcare system is broken and we just want to blow it up, right? So I've heard that several times. Everyone kind of shares that in their own way, but we certainly know that there are some system difficulties. It's hard to get records sometimes. Sometimes you show up someplace and they don't know anything about me. And so those things are very real, right? So we spoke a little bit before about planning. We don't plan for this very well, right? Sadly, we know this is coming, but yet when a patient all of a sudden comes to 18, we have heard many times that someone will call and say, hey, they told me now they can't see me anymore, right? So, and these kinds of changes, as Nicole highlighted early, transition is a process, right? It's not the same as a transfer, right? It's not just sending you to a new place. This takes time and energy, right? We also know on the provider side, again, I will own this too, that there sometimes our physician colleagues may not feel as comfortable taking care of some of the pediatric illnesses, right? So sometimes I think families fear that, but I think sometimes that fear is grounded, right? And sometimes we have adult providers who are not as comfortable taking care of kids with chronic illness, right? And so part of the process of finding who your go-to people are in adulthood means finding an adult provider who's not afraid, right? Finding an adult provider who can work with you, who understands, who will be willing to take the time and figure out where you've been and where you're going. We also have some challenges sometimes with our patient engagement, right? So we have a lot of teenagers who are thinking about a lot of other things in life as teenagers, right? And their epilepsy may not be the most important thing, or finding a new doc may not be the most important thing to them, right? We know that that happens. We also know that there's difficulties with communication. So all of these things make this process hard, right? So, and we all hit it in different places, but we know that this resonates in many ways. So I will call to mind this graphic that's on the slide right now comes from a consensus statement that was published in the medical world about 5 years ago. So this you can find online at a website, Got Transition, right? So, and if you go to Got Transition, you'll see this graphic, which was designed about 5 years ago when the American Academy of Pediatrics, in association with the American Academy of Family Physicians and the American College of Physicians, so all these big organizers, right, got together, these big professional organizations got together and said, we need to put some guidance into how we help families and clinicians transition, right? So there are many ways that this can happen depending on where you are and what your system is. But it talks about various things, including discussing a policy. What does your policy look like? Tracking progress about how your patients are doing, trying to assess their skills and their readiness, right? Coming up with a plan, executing that plan, and then eventually they actually make the transfer, right? So you'll notice that in all of this, the transfer to just a new doctor and a new epilepsy specialist is kind of way far on the right. It's like step number 6, right? There's all these things that we want to be thinking about ahead of time. And again, to echo before, if you're not, or if you haven't started thinking about it, I would start thinking about it and start having those conversations now with your current providers. And finally, I will say, does this help, right? So when we start to look at how we do this, because we know that transition planning is happening differently in different places. So we at Mayo, Arizona, we offer a clinic where we meet families, and we have a multidisciplinary team made up of the people up here. And so it's myself as the general internist and pediatrician, it's Dr. Hoerth and Dr. White as the neurologist, it's Nicole as our social worker. We all come together and we talk with families and patients, and then we help to figure out where do we go from there, right? Who do you need to see for neurology? Who should you be seeing for primary care? Who else do you need to see? What kinds of supports does your family need? What are we doing about school? What are we doing about insurance? All of these things that go into successful transition. We know that there's not only one way to do that, right? That is how we do it in Arizona at Mayo. But we know that however we do it, right, that yes, it does make a difference. So there have been some small studies in the medical literature that shows that if we start addressing this, if we start talking about healthcare transition with families and we follow some of these steps that we've laid out that we think are important, it does improve outcomes, right? It does improve the way that we perceive ourselves to be doing, right, with regard to our epilepsy or whatever the illness may be. Our patients attend more visits. They don't come to the emergency room as often. So there's definitely data to suggest that, hey, the time you're putting into this on the patient side, on the family side, on the clinician side, it matters, right? And it does end up resulting in better outcomes, right? And like what Dr. Hoerth said at the very beginning, the needs of the patient come first. That is what we believe at Mayo Clinic, right? And we really do believe that this work really helps in that. Finally, I will say just a little bit more about the transfer of care versus the transition of care, because I think this is an important concept that these things are not interchangeable, right? And we know that we're speaking to we're all in the same mind there, but remember that a transfer of care is usually something that starts with your pediatric team, right? And many times it's associated with a specific age, right? So that we transfer our patients at whatever age, 18, 21, 25, whatever the case might be, right? So sometimes there's a transfer of records, sometimes they'll fax over whatever they want to, and sometimes not, right? What we would advocate for here is not necessarily just a transfer, but a transfer as part of a much longer process of transition, right? For all the reasons that we mentioned before, right? So if you leave with anything today, I would say from the generalist perspective, transfer and transition are not the same thing. We know that. And so you want to start advocating for the process of transition. Start those conversations now, well before the actual transfer to the new person happens. And one more thing I just wanted to include before I turn it over to my my neurology colleagues. We know that there is a big jump, sometimes a chasm. It feels like a chasm between the pediatric healthcare world and the adult healthcare world, right? And since we all grow up in the pediatric healthcare world, that's what we know, right? We know that, things happen little by little. We know that sometimes there's a little more hand-holding. We get to know everyone in the pediatric world. And I say that as a pediatrician, right? So I'm not just blowing smoke at you all. I get it, right? And then we go to the adult world, and we know that sometimes things are very abrupt. The whole office looks different, it feels different, they talk different, right? There's all kinds of things that are different culturally in those two places. And we know that sometimes that's a barrier. And what I would say is those are realities about the adult healthcare world, right? So that we're all aging into, right? And so this process helps us prepare for that. And I will also say that it's important to find an adult provider who you feel like you can really connect with. And it's not always the first one you meet, right? So not all adult providers are the same as pediatricians, right? So, but there are some who will get it, and what we really want to find is somebody who you feel like gets it, right? And that's part of this process as well. So I will now turn it over to Dr. White to talk about transition just specifically from the neurology and epilepsy side.
Okay, so I do the subspecialty work. So in addition to what Dr. Kruger has already talked about, I'm going to talk about why this stuff is important in epilepsy in particular. So in epilepsy, we know this illness has a big impact on life in terms of quality of life. Causes feelings of isolation, especially as children continue to get older. For the most part, if they have uncontrolled seizures, they're not able to drive. They can feel isolated. They can feel different from other kids. They can feel different at school if they have seizures at school, if they have seizure action plans, if they have accommodations at school, they can feel different from their peers. If they miss school due to seizures, they can just feel different. And we all know from growing up and going to school, nobody wants to feel different, especially when you reach the point of middle school, high school. It's quite an adjustment to make. So essentially having epilepsy can make people feel less independent, and that's already something that's hard to take on, but especially in childhood. So patients 12 to 25 years in particular are unique, and this is kind of the target audience we're discussing today. They're not fully children anymore, right? They're kind of establishing their own boundaries, their own sense of independence, trying to figure out who they are. They're developing their own sense of autonomy, but they can reach more independence in their medical management if they're given the opportunity. But we all know that's a little bit different in each family. Sometimes we have mom and dad that do everything for the kid, and the kid sits in the back seat, and they like it that way. They want it that way. They never want to fight to do anything themselves. And then we have sometimes the kid who wants to do everything themselves ahead of time. It's all different between kids, but they're not fully adults yet. It's a So if you see from the provider standpoint, there's quite a difference. If we look at this first box, you see that adult epileptologists, for the most part, thought that patients should transition either just under 18 or at 18 years old. Certainly not many thought over 20 years old. Pediatric neurologists, on the other hand, most of them thought 19, 20 plus. If you look down in the next red box, highlighted in blue there, this is for patients with intellectual disability. Same question. This is even worse. It's more exacerbated. If you look at the pediatric neurologist column, again on the right, 40% of pediatric neurologists thought there should be no transition at any point. And then as far as this last column in the first box, the age to begin preparation for transition, which is what we were just talking about. There's, again, quite a difference here. Over 18 begin preparing for transition is over 50% of pediatric neurologists thought that was the appropriate age. Not to hate on pediatric neurologists, I'm just pointing out the differences that we all have between them and why we kind of need to come to kind of uniting thoughts in terms of this. And then, again, just pointing out on the right here, this differences in clinic environment. This is what Dr. Kruger was just talking about, differences in clinic environment. This is the reason that they thought was so significant. Oh, well, I've been seeing the same epileptologist, the same neurologist my whole life. This is why we shouldn't transition. 85% thought that was a significant reason. So, and then this is patients who are in a transitions care program versus those who are not. And we highlighted follow-up duration and then age at the time of their chart review years. So as a whole, the patients who were in a transitions care program had a longer follow-up duration of 18 years on average versus 15 years. And then they were at an older age at the time they were able to review their charts. Just showed a better outcome in general. And then this is just a graphic showing the Epilepsy Monitoring Unit, or EMU, admissions to Mayo Clinic, Arizona over the last several years. The green box is patients less than 26 years old, and then the blue boxes are patients 26 years old or greater. And if you'll see, it's been pretty steady from 2019 to 2023. We have about a quarter of the patients are 26 years old or younger. So that's a pretty good number of patients. Quality of life scores. This is something we assess in all patients with epilepsy, but this is something we found that impacts younger patients more significantly than older patients in terms of emotional well-being, social function, energy levels, fatigue, cognitive function, seizure worry, medication effects, and then their overall quality of life. And this is something we assess in every patient with epilepsy. And then especially significant was the social functioning score, emotional well-being, and seizure worry. And you can imagine why, especially at that age as they're transitioning through their adolescence and into adulthood. This is something that they're going to worry about with that increased burden of epilepsy on their backs. And so aspects of care and healthcare transition readiness. So this is kind of what we do as a partnership with the patient, the family, and the medical team. We meet with the team. We've got the primary care provider, the social worker, the child life specialist, as we mentioned, and then the subspecialist. And we meet with the patient and the family, and then we can break off and meet with each individually as well, which is great. We can hear from each of them individually and hear their individual needs. And I think that's something that's kind of essential to do. We can determine where help is needed, things that we can't address as neurologists or would overlook. And then we can establish obtainable goals going forward. And then what makes transition readiness successful? This team-wide approach that we have. We don't let anything fall through the cracks. We don't send a referral paper and say, see ya, it's been fun. We learn the patient's full individual story, not just from the patient, but from their parents who've been following with them the whole time as well. We listen to the family's concerns and needs going forward as the patient's, getting older. We've got committed team members, the knowledge of the process. We've got a thorough assessment from everybody involved. We've got questioning, observations, communication, advocating, and treating patients as equal members of the team when we're doing so. So with that, I will hand it back to Nicole.
So now we're going to talk a little bit about the psychosocial needs. It's obvious that you are very well versed right now about what we mean when we say transition readiness, but there's so many components related to transition readiness, and psychosocial needs is a big part. So my role as the social worker is really to assess all of those other things that are non-medical that are impacting you and your family, and what are the barriers to your child and to you as a family being successful in this next stage. So I want to know, what does medical literacy look like for your child? Is your child able to articulate what's going on with their body and what's going on for them? And obviously we have kids across the spectrum of ability and across the spectrum of severity. We want to know about any mental health concerns that you have identified through the course of childhood or up to that point. We want to look at legal considerations. Have you thought about what is going to happen when your child turns 18? In the state of Arizona, they have adopted supportive decision-making as part of that guardianship spectrum, where it's not full guardianship, but there is a team approach to supportive decision-making for patients with disability or chronic illness. Your state might have something different, but are you informed? Do you know what you're supposed to be doing? Do you know what your child is eligible for, or what is going to be a good match for you and your family? Have you thought about the day when maybe you can't care for your child any longer? Maybe you see your child as always living with you. Maybe you see your child as being able to have a roommate. Maybe you see your child as, if they learn the right life skills, they could probably be in an apartment by themselves. There's a spectrum here. So you want a team that's going to talk to you about this spectrum. We get so hyper-focused on the medical. By the time they turn 18 and someone asks you what's going on related to psychosocial, well, I don't know, I haven't thought about that yet, right? Haven't gotten to it yet, because your world of advocacy is every day, every moment for all the years. So you don't really have time. So what we want to do today is encourage you to take the time, even if it's 10 minutes a day in different aspects of this care. We want to know about goals and career setting. We have some patients that need to learn life skills. They don't know how to budget. They don't hold their own bank account, but there are other skills that they can do. So maybe we're going to direct them into vocational rehab and career setting that way. But then we have other patients in college. And in the state of Arizona, there's a lot of colleges that have specialty programs related for people with chronic illness or disability. Maybe your state will have that as well. I don't know, but I would definitely look into it. We want to know about the history of surgery, how ready is your child to transition, and how prepared have they been? Have you been talking at the dinner table about what's going on with their health? Do you even bring it up? Some families kind of don't want to talk about it or whisper in the kitchen, and that's what we can't do because they're getting older. So they need to have some grasp, even if it's just 3 words or on their communication device to say what to do in an emergency. So when we think about this adjustment to illness and emerging into adulthood, we mentioned before that we have a child life specialist, and her role is to really look at medical literacy in the hospital setting and to be able to help your child cope with all of the things that are happening. So think about the EMU unit, right? Some of our patients are doing really, really well, and some have issues with anxiety. They have maybe some medical trauma. Maybe you know of a little trick that works really well to help your child be calmer versus things that really agitate them. Like maybe it's the sounds of the room, maybe it's the lights. So the child life specialist assesses that. But she's also kind of going to assess that preparedness of the child too. So she's part of our team, and she helps us to really understand what works for kids in the hospital setting as they turn into young adults. So what do we do today? We want to start with medical literacy. These are some questions that to think about and to consider for you and your family. How well does your child understand their medical condition? If a teacher or a medical provider were to say to your child, hey, can you tell me about your medical condition? What do you think they would say? It's not necessarily what you've told them. It's what they've understood, right? So think about it from that perspective. How would they answer this question, and is it accurate? How independent is your child in managing their own health? We have some patients who will never manage their own health, but there are things they can do to start to learn. So starting those conversations and seeing where that line is for them to start being a little more independent. For some of our families, it's helping them understand which color medication they're taking at which time of day. For some, it's knowing the name of the medication. But are they helping you? Are they filling that pill box? I'm Italian. You see me talking with my hands? I keep hitting this thing. I'm so sorry. So I would just say that you can start those conversations really soon, and they might surprise you in their potential. How would your child manage an emergency? Does your child know the medications they're taking? Can your child refill their prescriptions? So electronic medical records are the big thing right now. Everybody has them. There's a portal. Is your child able to communicate in the portal? Are they talking to the provider to say, hey, my 90-day subscription is about to be up? Probably not. You're probably doing that. Is there something in their phone? Is there something on the calendar to remind them, hey, we need to refill your prescription in a week, in 3 weeks? How can we start implementing these strategies? It's a team approach, you and your child, for them to be the patient that is able to advocate for themselves later. Community resources. What resources are available? So many families that I see, maybe they were connected with resources prior to the age of 18. The child gets to be 18, 21, and the family's like, I haven't reestablished with anyone. You want to reestablish. There's many, many programs for young adults with disability. You need to know what they are, and part of my job is to help find those bridges, but it is important to get connected. And there are services that your child can still be eligible for after 18. So you really want to be sure you know what those are. We know that all chronic illness impacts life goals. Epilepsy is definitely up there. We have some of our patients who've missed a lot of school, so they're unable to meet their goals because they've been behind in school. So we want to know if continuing education is an option. What is learning like for them? Are they better hearing information, reading information? On the medical setting, they're going to give you discharge paperwork. It's all written down. If the medical team doesn't know you're not able to read that, or you need information more auditorily, that's important to put in the medical chart. Vocational and career pathways, living independently, we kind of talked about that. Managing finances and budgeting. We could have a whole lecture about this and about services and about, federal income, Social Security income. But what I will say to you is there's a little bit that your child might be able to do, so try to figure that out. And then transportation. Many of our patients can't drive. Do you trust your child to be able to take the bus? What about Lyft? What about Uber? Do they know how to do it? Do you want them to do it? Do they want to do it? How are they going to get around? So many things, right? I mean, I could clearly go on. But the idea is we have to have these conversations. We want them to be independent. Some of that's a little frightening, but there's a process. You might go with them on the bus for a while. You might take the Lyft ride with them for a while. There's many, many different options. So this first question, we ask a lot of our patients and we get a variety of answers with their families of how much responsibility does your child actually have in a typical day. Are you requiring your child to make you dinner or lunch once a week? Why not? What if it's peanut butter and jelly sandwich? Do they know how to use the microwave? Help with meal planning. You could give them a meal a week for them to start. That starts the independent process. There's so many options for independent. If you think about your day and how much you're doing for your child, take a deep breath and say, is there any part of that that they could start doing on their own, that I could hand over hand start teaching them to take some of that responsibility, some of that independence? If you're currently with a provider that you've been with for a long time and maybe you're thinking about transition or maybe you just moved over, it's important to ask our pediatricians, what should my child be doing at such and such age? What's the expectation? What is independence going to look like? Sometimes I think medical providers maybe don't elaborate on this conversation because it's scary or because they don't want to bring up the elephant in the room. But you need to know as a parent, where is my child going and what is the possibility and the potential for them? So it's okay to ask your providers these questions. What can I start doing at home to help my child build their confidence in healthcare literacy? What programs are available? What support should I access when they turn 18? How's the school system involved in this? We work a lot with the schools. And should my child disclose about their disability or chronic illness when they go on to school, when they're starting to be employed outside of the home? Like, what kind of conversation should they be having about disclosure? Is that okay? And that is a personal preference, and that's a different lecture, but that is something you should definitely be thinking about related to, because what happens if your child is working in Target and they have a seizure and nobody knows what's going on? Does your child wear anything on their body to say a medical alert system? Maybe it's on their shoe, maybe it's a bracelet, maybe it's in their phone. Does anyone know in their circle that I have a medical issue? In case of emergency, this is what needs to be done. Sometimes we feel like we don't want to do that because we're shy or we're embarrassed, but honestly, we're looking at what's the best scenario for your child. That's the end of our lecture. We are open to taking questions, and we appreciate your attention, and there's so many of you, so thank you very much.
We'll open to questions. I guess I'll help moderate. I think I saw your hand in first as I was coming up.
How long is your clinic visit when you do this multidisciplinary clinic? And how often? Like at what age do you start? Do you do it for 10 years? Do you do it for 1 year?
Very good.
Like, is it once or is it like over a period of time?
That's a great question. So there's not a lot of places that are doing this type of clinic. I think I've heard of maybe one other where there's an adult hospital that's like saying, hey, kids, come on over. We kind of started with an idea of, and it's morphed over time to be very upfront with that we would kind of do an ongoing sort of thing. But I think what seems to work better is we do like a one-time consultation, and we've blocked.
When we do it for all of us together, we have take 90 minutes basically,
Yep.
right? So, and that's 90 minutes inclusive of the time they spend with the neurologist, the time they spend with me in primary care, the time they spend with social work, and the time they spend in child life, right? And in that time, we spend time with all of those things, and then we come up with kind of an action plan moving forward, right? So, will you continue to see for primary care? That could
because we're on the adult side, we don't have the luxury of that consistent contact with families as you do on the ped side. In the ped side, the social worker role is very, very hands-on. On the adult side, it's a bit different. So I rely on my providers to tell me in their follow-up appointments if there's something I need to follow up with families. They have my information, but you know how that goes, right? So if at the appointment they recognize, hey, the family still needs help with this, then I would reach out. So it's a one-time 90-minute consultative kind of overview appointment. Great question.
But I refer back a lot, so I will often say, "Can you call
She
this
does. She refers back a lot.
Reach out to him again, he hasn't done what he wants to do.
Right.
Other questions? Yeah.
I guess I have a comment and question. I want to know whether you agree with my son's pediatric neurologist that kind of sheds light on their statistics. They mentioned that they would like to keep our kids till they're like 25 because when they move over to epileptologists or adult neurologists, they tend to be a little nervous about taking that age group
Yeah.
because they are more, they have more experience maybe with even much older
Yep.
people. So they have a hard time transferring over. So I think that's why they want to keep them as long as they do. How do we find, or how do we, I don't know, we don't know how to find who's an excellent
So
adult neurologist that knows how to work with
with younger group, yeah, that's a very common thought among the pediatrics. So in that study that Dr. White was showing, I think that could be a bit of a misconception. So most, and I'm going to explain this a little bit more, maybe from my assumptions from why we see that. As a trained neurologist, we are trained in things like Alzheimer's disease, Parkinson's disease, stroke. As a group, neurologists tend to take care of older people, with the exception of the epilepsy specialists, and I guess the headache specialists too. So that survey was, the pediatric neurologist versus the adult epilepsy specialists, right? So I would think and I would hope that most epilepsy specialists, like the ones that are here and presenting all that stuff, feel a bit more comfortable with the younger age groups than the older age groups. If you were to go to a general neurologist's office, which some may be very comfortable with younger people, but you might find some variability there. And I'm making a lot of assumptions there, but any other thoughts, Dr. White?
I would agree.
Yeah, okay.
So we should look for
Epilepsies. Yes, I would think so. You're going to have a bit more help. And then also I'll add on that could be like a bit of a fit, like Dr. Kruger was saying, is, you could show up to that office. You might see a lot of older people in the waiting room. Don't always make that a concern of yours, but that interaction with the neurologist, that might just be the right thing for you. And so yeah, and it doesn't have to be like a transfer of care and all of a sudden now you're committed. We've had people come see us and they're like 18 and they're like, you're great, I'm going to go to Children's Hospital and just kind of finish it out with them and maybe kind of check in like maybe once a year, but have them and then eventually make the transition. We've had a couple people do that too. So. Yeah. Oh, great. Yeah. I think it's individualized.
Yeah.
Or I was gonna jump in.
I thought
Yeah.
that was good.
Okay. Yeah.
It's up to you and your family. Like Dr. Hoerth said, right now we have some patients that are 1 foot in both systems because there is a process. So depending on what the goals are, what we know on the adult side is they're going to specialize and look at different things than on the children's side. So really thinking about where you are as a family and what he's ready for. I would say definitely no later than 25. But you want to at least start part of the process, even if it's not specifically going to the doctor, but some of those other things we talked about too. So he's more of an advocate for his health. So it's really up to you.
And we have like certain situations where it's like, I'm ready to start a family. Well, then maybe you need to move to the adult, like, and not for the males, but like for the, I'm ready to have a baby and get pregnant. It's like, no, you need to go to the adult. You're ready to be for the adult side. Some obvious things, but yeah. Questions we answer all the time in clinic.
Yeah.
Yes.
So it's illegal for them not to hire. I'm just letting you know that. But your vocational rehab in your state, that's kind of part of their role, is to help him either get the soft skills he needs and help with that transition over. When it comes to identifying his epilepsy, again, that is completely up to you. You want to think about, if I were to have a seizure in this environment, what would that look like, and who would be able to help me? What do I typically need? If I need emergency medicine, rescue medicine when I'm having a seizure, and none of my friends or my colleagues know that, there can be a big bubble balloon at the target when there didn't need to be. So we can't tell you what to do, but having that information and having people to support you in that is the most important. You also should have an epilepsy foundation in your state, yeah?
Yes.
And so they can also help with that advocacy about how to disclose and when to disclose. And there's some employers that welcome accepting people with disability to work for them. So I would also kind of look for that as well.
So I think if there's more questions, we might be able to step outside, or if you guys want to swing by our booth, it's just right here. I think we need to transition. But thank you guys.